Audible ആണോ ഡോക്ടറെ?
Yes, ma'am. Audible ആണ്. Hi, ma'am. Good evening, ma'am.
Good evening.
Okay, shall we start, Dr. Rahul?
Doctor, let's wait for one more minute, then we can start.
Okay.
Doctor, we can start.
Okay. Good evening, everyone. A warm welcome to all the respected doctors, scholars, and all the participants joining this evening with us. Welcome you all for today's session of Balaveda, an exclusive CME series for pediatric disorders and its management. It's an academic initiative by Kerala Ayurveda Limited, presented as part of the 80th year legacy celebrations. And I think you all know we have started 2 CME series prior to this Balaveda. One was like Sandhi Veda, which is related to the musculoskeletal disorders. And the second one was Twak Veda, which was regarding the dermatological disorders. And after the success of these 2 CMEs, we are moving forward to the third one, that is Balaveda, which is dealing with the important domain of pediatric disorders. And our aim is to provide a meaningful academic platform to discuss pediatric challenges and highlight the role of Ayurveda in the treatment. And today's session focuses on developmental and behavioral disorders in children and Ayurvedic perspective. And it's my privilege to introduce our esteemed speaker for today's session. We are deeply honored to welcome Dr. Roshni Anirudhan, Professor and Head of the Department of Kaumara Bhritya at Government Ayurveda College, Thiruvananthapuram. Our speaker truly needs no introduction because she is such a familiar and renowned personality who has conducted many national and international level seminars. Still, as a formality, I would like to briefly present a short profile before we begin. Dr. Roshni is a senior academician and clinician with over 28 years of clinical experience and more than 2 decades of dedicated work in developmental pediatrics, particularly in the management of autism spectrum disorders, developmental delay, and behavioral disorders in children. She is a renowned resource person for many national and international seminars. And about her academics, she has completed her UG and PG from Government Ayurveda College, Trivandrum, And it's truly remarkable to say that she has completed PG in 2 subjects. One is Samhita and Siddhanta, and another one in Kaumaravritya. And she holds a PhD in childhood autism from Kerala University and has undergone advanced training in pediatric advanced life support by American Heart Association and childhood disability management by KUHS. And she has served as principal investigator for multiple central and state government funded research projects. And she is a recipient of the prestigious Atreya Award from Government of Kerala in 2019 for contribution in the field of Ayurvedic pediatrics. And she is also awarded as a Best Project Coordinator in 2019 by Government of Kerala for her pivotal role in a project called Snehadhara, which is an Ayurvedic management of developmental disability in children. And we are proud to say that in her early career in 2010, she was awarded as the first runner-up for National Level Research Award conducted by Kerala Ayurveda Limited. So we are proud to invite you, ma'am, for today's session. And before we begin, I would like to inform the participants that our Q&A session will be held at the end of the presentation, and you can type the queries. If any queries, you can type in the chat box, and we'll be discussing in the end of the session. So on behalf of Kerala Ayurveda, I'm inviting ma'am for today's session. Over to you, ma'am.
Thank you. Shall I share my slide?
Sure, ma'am.
Is it visible?
Yes, ma'am.
So, good evening, one and all. And today I feel so happy to meet you all. I'm extremely happy to know that KL is hosting such a seminar series. After all, we need to be updated regarding the recent advances and different specialities, what is going on in Ayurveda. So it is like promoting knowledge sharing in between the practitioners. It's a great thing which a firm like KL can do. As well said in the introduction, KL has always been a helping hand or a encouragement for those who are in the field. So I am feeling proud and extremely happy to receive the research award from the KL in my early years of my career. That is way back in 2009 for my research in cerebral palsy management. So today I am here with the topic developmental and behavioral disorders in children. So the Balaveda will be dealing with many aspects of pediatric disease where a specialty care should be needed. But we would like to share the style of management or the perspective of management in such disorders. So developmental and behavioral disorders. The childhood is actually different from the others, owing to their classical the growth and development. Growth is actually the physical growth, what happens in the child, or physical increase in or a structural increase in height and weight of the child. The baby, when he is born, it's only 2.5 kg with a maximum length of 50 to 51 centimeter. So such a tiny baby grows into a fully grown adult. Structurally, the baby is growing in terms of height, weight, head circumference, chest circumference, and everything. The baby is growing structurally. So we will call it as growth. And functionally, also the baby is developing. So I'll call that development is a functional aspect or a functional growth, functional improvement. As of from the actually lying flat on the baby, mother's lap, the babies slowly learn how to hold the head. Slowly the baby learn how to sit with support, and then the baby learns sitting independently. Slowly the first steps of life starts. Walking with support, and then he starts without support, then running around. So the baby is functionally acquiring many skills. So development is actually determined or denoted by the word functional attainment of different skills in the baby. So today we'll be dealing with developmental errors. Because growth is comparatively a minor category where the structurally the baby is growing. So growth errors are generally reduction in height, reduction in weight and all. When compared with the developmental errors, growth errors are of minor gravity. So development is again, that functional development is again divided into 4 aspects. Gross motor development, fine motor development, speech and language, personal and social development. So it's very simple. The baby acquires gross motor skills like head holding, sitting, standing, running, climbing the stairs, so on. That is actually gross motor developments. Grossly, it will be visible. Motor skills are needed to attain this gross skills. So it's called gross motor development. Fine motor skills are actually fine tuning of the muscles and nerves to do certain activities like eating, writing, and so on. So skilled motor activities are called fine motor development. Speech and language. Baby can hear, even intrauterine life, baby is able to hear. But later on, after birth, like within a period of 6 to 7 months, the baby starts actually making sounds like ooh and cooing. We say that the baby is cooing. Slowly, by the age of 1 year, baby starts speaking. It's like first words of the baby starts. Then slowly the word joining will be the making sentences, small stories, narration of the school events, and slowly the baby starts speaking well. As we are speaking, baby's ability to converse develops fastly. That is a speech and language skills. And then comes the personal and social skills. The personality of the baby starts developing and it learns how to interact as a social being, how to smile at the mother, how to interact with a stranger whom he should be having contact or relation with, whom he should avoid. Everything he learns, how to behave in front of a stranger, how to behave in a close family circle. That is actually the personality of the child is developed. So in total, the development is categorized into 4. The gross motor activities, fine and skilled activity, the speech and language, and that his behavior or personality. So any error in this phase of development is a serious issue. So let us see each development with more detail so that we can go into that disorders thereof and then the management. So, as I said earlier, gross motor development. This requires actually the big muscles to maturation of the big muscles and coordinated activity of the neuronal control over these muscles should be there. Actually, these motor developments are the maturity of the brain axis, central nervous system, which gets matured and gets attained. So normally a baby should attain the head holding or a neck holding by 3 months, turning over by 4th month. Slowly the baby starts learn to sit with support by 5 months. And the baby should sit without support by 8 months. Slowly there is nothing to remind, nothing to by heart such milestones. If I say in simple words, head holding should be attained at least by 4 months. Sitting should be attained at least by 8 months. And baby should walk at least stand at least by 12 months. So it's a multiple of 4. Head holding by 4, sitting by 8, and standing by 12. If these 3 milestones are not attained at this proper time, it's a development delay. Delay in gross motor development. So naturally, the baby should learn to climb or learn to run perfectly by 2 years. And he should learn to ride a tricycle by 3 years. Usually the first 3 milestones are very important. Head holding by 4, sitting by 8, and standing by 12 months. That is 1 year. So if at all you see a baby unable to sit properly after the age of 8, it's an error. If at all you see a baby who cannot stand by himself at his first birthday, again it's an error. So what Acharya has done very wisely that they have crafted certain developmental checkers in proper time. That is like Annaprasana Samskara with Upaveshana Samskara at 6th month. Upaveshana is like making the baby to sit. And you're supposed to introduce the first feeds at 6th month while the baby is sitting. So it's naturally an educational a development milestone checker. If at all the baby is unable to sit even with support at 6 months and unable to chew the food at 6 months or lick the food by 6 months, suspicious of an error. So naturally, different samskaras are told, like Padagavana samskara at 1 year. So every time a delay, it should be dealt with caution. A delay, a gross motor delay is an indicator of 2 things. Usually it's a neuronal delay, a delay in the maturation of neurons or the brain. But at times it can also happen due to a muscular involvement. Like certain diseases, myopathies can also result in such delays. Muscle disorders can also result in such delays. But many times, more than 80% of cases, it is usually a disease concerned with brain. Usually premature babies are bound to have a development delay, gross. We'll be dealing it in later. Next comes the fine motor. Fine motor, as I told you, it is like fine, skilled movement of hands, eyes, mouth, and even your walking also it is there. So the milestones like if soon after the baby, if you show a dangling ring in front of him or a lighted toy, baby may be looking at that light, but if you drag it slowly to the other side, he won't be able to follow it like evenly. He can't follow. He may look here, then suddenly look other side. So his muscles controlling the eyes are not properly able to have a perfect coordination to move it uniformly to follow the object. So slowly the baby eye muscles develop so that he is able to follow the objects. Then comes the hand movements. If at all you give a ball to a baby, he will grasp it like a crude grasp will be there. Both the hands will be used to have a crude grasp. He can't hold the ball with a single hand. So that is bidextrous, holding with two hands. Then after 6 months or 8 months, baby learns to hold it like a single arm. Even single palm is enough. We call it as palmar grasp. So if you give a toy at that time, like a toy like this, he will grasp with the entire hand. It's like we do it like that. If you give a like breakfast or something, a bowl of rice, baby will do it like grasp the rice like this and then drag it to the mouth and open like this. It's not mandatory that every single rice will go in. It doesn't know to pick it like this and go and feed it like entire. So it's like a full entire palm is needed to grasp the thing. So we call it as palmar grasp. Slowly by the age of 9 to 10 months, he learns to use the two fingers and pinch one thing precisely, focus at it, precise pinching, and then taking it to the mouth and having it. So that is pinching or a pincer grasp. That's again, these are all fine motor skills. Slowly after developing pincer grasp, the baby learns how to feed himself by taking things from the plate and putting it right into the mouth without spilling. By 1 year, it learns feeding is with all the spilling, dirtying all in and around the mouth. But slowly, by the age of 1.5 to 2 years, it learns to have the food without spilling. Similarly, turning of the pages of a book is also very similar to that. If you see a baby turning the pages of the book or color book, it's like the maybe 10 to 20 pages are hold together and it will turn like this. It doesn't know how to turn one pages at like this coordinated finger movement won't be there. So turning the pages of a book could again all the writing, scribbling, everything is fine motor skills. Have you seen this baby starts to scribble very in a very crude pattern. They will hold the pencil like this, initially pencil like this, the entire palm, and with much effort, it will start scribbling. And the scribbling will be like straight lines, straight horizontal lines initially. It is very evident because they usually scribble on the walls and all. So it is like perfect horizontal line scribbling in the initial stages. Then slowly as the baby develops, its horizontal lines will turn into circular lines. As it turns into circular lines, it's an indicator that the fine motor skills are mature enough so that you can teach the baby writing. So Vidyaramba or initiation of what in Malayalam we call Ezhuthinirtha can be done only after the baby has attained this scribbling in the circular pattern. Slowly, the baby can taught to draw, write, and everything. Dressing, everything comes under dressing by himself, buttoning, everything comes under fine motor skills. So, fine motor skill delays are not that, it doesn't exist independently actually. It's usually seen as a part and parcel of diseases having this gross motor delays. But certain neuropathies can also exhibit like distal muscle weakness, but it's not that common. Then comes the main error, speech and language development. Speech and language is like baby is starting to appreciate the sound, like turning the head to the sound. Then as the third month, by the age of third month, the baby starts cooing, what I call like, if the baby needs a mama to take him on the lap, he'll start like coo. That is a cooing, ooing sound, which is the first, that's the first sign of language development in a baby. So if you don't see a baby cooing by the age of 6 months, it's a pointer of an error. So usually baby starts babbling like ma, 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 or that's monosyllable, single syllable babbling by the age after 6 months. And it slowly learns to join the syllables like amma, papa, or like slowly learns to join the syllables. And by the age of 1 year, baby should know to speak at least 2 words with meaning. It's not mandatory that it should be mama and papa. It may be something else. But meaningful 2 words should be there by the age of 1 year. Then after 1 year, the language develops very fastly. Very fastly, like what by 1.5 years, baby has in his credit 10 to 15 or 10 to 50 words. And by 2 years, he learns to join 2 words like enne edukka, take me, mama come. So 2 word joining comes and he has a credit of at least 50 words, but usually he knows around 200 words by 2 years. So 2 years is like 2 word joining and then a credit of 200 words. So slowly joining the words, several words into big sentences starts by the age of 3 years. And he is able to narrate like something which has happened there at family or something. Slowly, that sharing of the recent experiences, everything starts as a paragraph, structural narration, sequential narration, everything happens. So this speech and language development is nowadays showing big errors, and it's a major area of concern now. Many kids has shown slowing in the language development, especially male kids are coming up. That prevalence of language disorder is more in boys than in girls. It should be dealt with much caution. May not be it's an isolated issue with the language. Language has 2 perspectives. That is receptive language and expressive language. I'll clarify it much bit more. Receptive language means the baby is able to hear and understand the meaning of the speech which he hears. Like receptivity is like ability of someone to understand what we are hearing and to comprehend the meaning. When I am speaking to you, you are able to hear me properly. So you are hearing my sound with the ears, and at the same time, the sound waves are being taken off to the brain area, auditory area, and it's converted into meaning there. So each and every word you are hearing, and at the same time, it's being converted into its meaning also. So when you hear me, you are understanding the meaning as well. So, but it's not a simple process. Many times, even if the child has the ability to hear, even if his auditory skills are perfect, he won't be able to understand the meaning of the sentence or a word which he hears. Means he is unable to receive your language. We call it as receptive language errors. So even if he is very intelligent, even if his hearing skills are perfect, he may not be able to receive your language. So naturally, what happens? He may not be able to express. You should have a proper expressive languages. Nowadays, these errors are more common. Today also, in my OPD, a mama came with a baby aged 4 years. So he was sent to that Anganwadi, the preschool. And the preschool teacher was saying that she felt that the baby is unable to process or receive the common commands. And mama took the baby to my OPD saying that I don't have much complaints regarding the baby because he is speaking well. He is speaking well means that when I asked in detail, the mama told that he is able to count from 1 to 10. He is able to sing nursery rhymes. So mama doesn't feel that there is a defect in speech. Here, what studio understood is that learning counting 1 to 10 is a by-hearted speech, which we learn with constant, when we hear that constantly with training, and the baby learns to by heart. But similar, it's a condition with rhymes as well. It's easy to by heart a rhyme, even if he doesn't have the receptive language. If he has a good hearing, he can hear that music and it by hearts. The simple example is that even without knowing the meaning of any of the nursery rhymes, we have by hearted it down in our childhood. So knowing the meaning is not a mandatory for by hearting the rhymes. But when I asked the baby, I asked the child that, what did you have for breakfast today? Then he didn't answer. When I took his attention, turned his face to my face, and I asked, what did you have for breakfast today? He was just smiling at me. Then I again asked, didn't you have breakfast? Did you have breakfast today? Again, he didn't answer. So when I asked it the third time, he was repeating the term breakfast. Echolalia was there. He was echoing that word. Then I asked the mama, won't he answer the questions? Then mama told that, no, doctor madam, he won't answer. Question answering he doesn't like. So then I asked the mama whether he will understand a story. Then she explained that I have watched, he doesn't like stories. But he understands all my comments. Then I asked her, can you ask the baby what you have breakfast? Then she asked the baby, what did you have? What did you have? Then the baby said, idli. So that baby could receive the mama's non-verbal or the non-verbal cues, and he answered. He was unable to understand our normal conversation. But baby was intelligent enough to carefully watch the non-verbal cues, and he could answer that. So it's a strict condition where the receptive language is erroneous. So many diseases are there where the receptive language is also erroneous. So he won't be able to understand, he won't be able to answer the questions. When we go on asking something, when I ask, what's your name? The baby will respond saying, what's your name? He will respond back. So we call it as echolalia. The other expressive language error is, I think everyone is familiar with. It's usually denoted as a delay in acquirement of language skills. Delayed like talking by 2 years. or 4 years. Usually the parents attribute to this delay to parental history. Maybe the father is having a delay in language acquirement or something like that. But it's usually nice to have an early intervention to correct it as early as possible.
Madam, can I ask a question? Like you have well explained about the clinical experience what you have today. So I'm asking in a clinical timing, in that timing, is it challenging to understand whether it is an actual problem? Because we'll be seeing the patient for the first time. So how we can, if a doctor is not that experienced, how we can see that in a single sitting, is it a problem or how we can communicate with the patient?
Yeah, it's actually, if you have such a clue in mind, it's very easy. Just ask simple questions without a non-verbal prompt. You shouldn't use your facial expressions. You shouldn't use any non-verbal cues, and just ask the question like a simple question. Usually, like usual questions like what's your name? Or such questions should be avoided, because the baby will be trained to do like show your head, show your eyes, that everything. Such questions should be avoided, because constant training will be done by the parent for such questions. So unexpected questions like, can you show your mama, or something like that, unexpected questions, but it should be very simple, can be asked. Receptive languages, language delays or errors are very common, and it's like missed by many of the practitioners.
Okay, thank you.
Even by the parents, they do miss it, because the common commands are usually associated with the non-verbal cue as such. Can you take that mobile? Mobile. That word mobile will be very known to him. So with a pointing, he will go and take that mobile. So if in the same tone, if you say that, don't take that mobile, don't take that mobile, he'll say, take that mobile and come to you. Okay. He won't get the meaning of tone. If I say, don't take that mobile, he will come to know that something I am like arrogant with him. And so it usually denotes gives a notion of a big no.
Okay. Okay.
So from tone he understands. He doesn't understand from the word translation.
Okay.
So receptive language errors are very common. So whenever you are encountering a language delay case, so do have a first check that whether he is having a receptive language perception clearly. Otherwise, do correct that, and before giving a medicine for the expressive language.
Okay.
Okay.
Okay, ma'am, we can continue.
So we were dealing with speech and language delays, and then coming to personality development, personal and social development. This personal and social development is a fourth one. We were dealing with gross motor, then we went across the fine motor, then dealt with the speech and language, and fourth one is the personal and social development. Actually, this personal and social development is a reflection of the cognitive index, or I will say that this is a reflection of IQ of the child. He learns to behave, how to behave to the external environment, how to regard it, how to reciprocate it. Everything is this by the means of this development. He learns to smile at mama. It's not necessary at mama alone. If someone, by the age of 2 months, if anyone smiles at him, he should smile back. We call it a social smile. It's the first sign of developing a positive attitude towards the society. The biggest disorder affecting this personal and social development is autism or autism spectrum disorders. They won't smile back. They won't regard your smile. They are not actually angry with us. They don't regard it. Even if you smile, even if you make him like smile at him or tickle at him, he won't smile back. And recognizes the mother and be affectionate to show the affection to the mother. That by 3 months. And by the age of 6 months, the male milestone is that he loves him. That's a self-love. Smiling at his mirror image. He loves to watch the mirror, his own mirror image, and he is so happy for that. He smiles at the mirror image. And this milestone says in the entire life, even at these later ages also, you are very happy seeing your image in the mirror. And by the age of 9 months, baby learns to wave bye-bye. And simple passing on ball game by 1 year. And slowly the baby develops. By the age of 8 to 9 months, baby should know who is in my inner circle and who is a stranger. Up till this 9 months, baby will be interactive to everyone in a similar pattern. Even if you go and take the baby, he will come to you like his mama. But by the age of 9 months, he learns you are a stranger. You are not my inner circle. So he will show a stranger anxiety. He won't come to you very easily. So if a baby is not showing a stranger anxiety by the age of 1 year, it's not a good sign. So later the personality develops. He develops to control his bladder by 1.5 years and bowel by bowel by 1.5 years and usually the bladder by 3 years. So disorders thereof, anything I may need to clarify regarding this developmental acquirement? If you are thorough with that, shall I proceed?
Yes, ma'am.
Okay.
Yes, ma'am, you
So-
can proceed.
Oh, so regarding this development, I'll be narrating very few diseases and will say I'll narrate the common disease and say how to approach that. So many categories of diseases are there when the development is erroneous. So usually I'll come to static encephalopathies in the initial stage where there is an error in the brain development. Usually it may be a development of the brain has not happened in a good pattern in the intrauterine time. While the baby was in utero, the maximum 80% of the brain development happens inside the uterus and only 20% happens after delivery. So in that 20%, majority happens under the age of 3 years. So any error in the brain development in the uterus during the time of delivery and before up till the age of 3 years. Any diseases thereof can hamper the development or any injuries during the birth like oxygen deficiencies, a cry is delayed or intrauterine infections, placental insufficiencies, or a chromosomal error, genetic abnormality can all hamper this development of the brain. So usually the main villain in there is the premature delivery nowadays. The baby is born before attaining the maturity, that is 37 completed weeks. So baby is born before that, is not having the enough time to have an good brain development in utero. So baby is prone to have a brain insult. So such babies are prone to develop hypoxia during the delivery process. So this hypoxic insult can happen to the brain. We call it as hypoxic ischemic encephalopathy. So due to a brain insult, a defect happens in the baby. So that's called static encephalopathy. Cerebral palsy is a very common example of that. Actually, the name is a misnomer. It's not only the cerebrum which is involved. It's a palsy for natural, but it can be a cerebellum as well. It can be midbrain as well. So a palsy due to an abnormality or an insult to a brain can be called as cerebral palsy or a brain palsy. It's called a static encephalopathy. Why? Because it won't worsen over time. The brain damage maintains that status quo. It won't worsen. It's a non-progressive disease. Usually that movement or gross motor skills of the baby are involved. The posture, the head holding, the sitting, standing, walking, everything is defective. Why? Because a brain insult happened in the brain before the age of 3 years. The prevalence is like 1.5 to 2.5 in every 1,000 births. So then and there, you find a baby with this gross motor development delay. This is a snap of a baby having this cerebral palsy. See how the head holding is very defective. He can't hold the head straight. It's a drooping head. See the hands, how he has turned it. He will turn the thumb finger like this and curl. It's called cortical fisting. He won't do like this. He'll curl it inside and then. This is called cortical fisting. This indicates like this side of my cortex pointing towards the defective cortex. So if I turn this like this and curl it like, my thumb finger indicates towards the defective cortex. So we call it as a cortical thumb, indicating towards the defective cortex. See, the baby has also done it like that. He won't have an independent thumb movement. And the legs are also scissoring. We call it as a spastic cerebral palsy because spasm is very pronounced over there. Cerebral palsy is just as I told, it's a misnomer. It's a palsy due to a defect in the brain. Usually the spastic cerebral palsy is very common where the spasm is very pronounced. Spasm of the upper limb, spasm of the lower limb. We will feel that if at all the baby had no spasm, he would have walked very nicely. Spasm, we feel that spasm is the main error over there. So spastic CP, maybe spastic CP can again be divided into diplegia. Diplegia where only the lower limbs are involved. Spasm in the lower limbs alone. The other upper body, head, everything is perfect. Spasm is only in the lower limbs. So head holding, sitting, everything will be perfect. But when the baby starts walking, he won't be able to walk. So we call it a spasm in the lower limbs alone. We call it as diplegic spastic CP. Usually this is a classic presentation of premature babies. During the premature labor, what happens? The corticospinal tract supplying the lower limbs get involved. This tract supplying the lower limbs succumb to the hypoxic insult very fast. So head holding and upper limbs are spared. Naturally, the spine is also spared, but the lower limbs get involved. So head holding, sitting will be perfect, but when the baby won't baby won't be able to stand by the age of 1 year. When the baby starts to stand, he will be standing in toe, with the toe touching the floor. Hemiplegic CP is one side of the body is involved. The upper limb and the lower limb of that side is involved. Quadriplegic means all the 4 limbs. It's a severe case. All the 4 limbs are involved. This snap which I showed earlier, This one is a picture of quadriplegic CP. See, all the four limbs are involved. Then other types are extrapyramidal. I'll show the videos and then it will become comfortable. Extrapyramidal CP is like that choreographed or dancing movements are very common in that. Then extra cerebral, I will show the videos and then explain. These are the pictures of spastic CPs where spasm is moved. See, in the first case, you can see that one side of the body is involved. Up that right upper limb and lower limb is involved. So that's the right-sided hemiplegic spastic CP. So second one, the upper limbs are perfect. The settling is also perfect. Only that lower limbs are involved. So that's a spastic diplegia. See, all his four limbs are involved. It's a quadriplegic CP. See, this is the video of spastic CP. See, this is the classical toe walking. He is walking with touching the toe alone. His heel is not touching. And also see that his limbs are scissoring. Like a scissors, he is placing the limbs. The classical diplegic spastic CP. Hope the video is visible for you.
Yes, ma'am. It's visible.
See, it's entirely different from this baby. Both toes are touching, feet are touching very clearly, but he is unable to maintain the balance. Wide spaced limbs are there. Spasm is not at all there. So here the spasm is not the main villain. Here the body balance is actually regulated by cerebellum. Cerebellum is not functioning properly, so he is unable to maintain that balance. So we call it as cerebellar, or ataxia is the main issue. So we call it as ataxic cerebral palsy, or a cerebellum is the culprit behind. So cerebellar ataxic CP. See the next video. Spasm is not there. He's trying to touch that towel, but his hand alone is not moving. He's moving his other hand as well. Unwanted dancing like movement of the limbs are there. So we call it as athetosis or choreoathetoid type. This is actually found when the babies, when the babies succumb from severe jaundice. Usually these babies naturally have a jaundice at the time of delivery or soon after the delivery, within 1 week. Naturally, physiologically, they are bound to have a jaundice. But certain babies, due to some diseases inside, these babies suffer from severe jaundice. Full body gets yellowish. And this unconjugated bilirubin will cross the blood-brain barrier and get deposited in the brain. Once the deposition happens, it's irreversible. Otherwise, the usual jaundice is very much reversible with phototherapy. this unconjugated bilirubin, which loads inside the blood, can be converted into its photoisomer and get excreted when we can excrete it through the urine. It's very easy. It's not like usual jaundice, which happens in adults. Unconjugated bilirubin excess, which happens in babies, are very easy to get to remove it from the body. Like the unconjugated bilirubin is water insoluble. But when we place the baby under a phototherapy unit, this light rays are able to convert this bilirubin underneath the skin into its photoisomer. And this photoisomer is a bit brown-black colored and it's water soluble. So naturally, you might have noticed that when some doctors are placing these newborn babies turning yellow into a phototherapy unit, the baby will be turning black. So I have seen many times that the grandmothers won't be permitting us to keep the baby in phototherapy, because they will be saying that now the baby is having a very golden charm. If you keep the baby under this light, the baby's complexion will be lost. It may turn brown or black. So we won't be permitting. But this jaundice, if it's increasing, is a serious disease. So this phototherapy is a very effective management for converting this bilirubin to a photoisomer, and the baby will excrete it out through the urine. If not managed properly, usually it happens in rural areas when this jaundice left and gets unmanaged. So this bilirubin has every chance to get deposited in the brain, and it leads to this type of choriothetoid CP. And along with that, the affinity area is vestibular cochlear nerve. So the baby develops deafness also along with it. So whenever you see a baby with this dancing movement along with a deafness, sensory neural deafness, the first question you should ask is that whether the baby had an exaggerated jaundice during the birth. So then the patients will say that, oh, madam, baby had jaundice. It was left unmanaged. We thought it will be gone when you showed the baby to that slanting sun rays. We showed the baby to slanting sun rays morning and evening. But slowly the yellowish coloration was worsening. But irritability was not seen. Suddenly on the sixth day, the baby developed seizures. We took her to the hospital, but by that time bilirubin had gone too much high. And from that time, the baby is not having the hearing capacity, and these dancing like movements are also there. So usually it's due to bilirubin encephalopathy. So we had seen 3 types of cerebral palsy. One was the spastic type. One was that cerebral or ataxic type, and the other one was choriothetoid type, or I call it as bilirubin encephalopathy. So the standard management or a conventional management is like physiotherapy and physiotherapy alone. Only exercises are there to increase the brain, to improve or stimulate the muscle to work hard, thereby expecting that the brain repair or the brain maturity will happen and clear out the disease. No other management is there in conventional medicine. Occupational therapy is also similar style, where we give daily activity life training to the baby, to dress it up, to slowly walk, everything. It's a polished form of physiotherapy. Then several splints, casts, and calipers are used to help the baby in walking. And certain drugs like neuronal toxins are also used to make that spasticity, relieve that spasticity also. Certain surgeries are also there to lengthen the tachylus, which is causing the toe walking. But sad to say that no treatment there exists to increase or stimulate the brain development. So naturally, there comes that there is lies the scope of Ayurveda in triggering the brain development, and all these therapies which are laid down by the conventional medicine like physiotherapy, occupation therapy can be well incorporated into Ayurvedic management style as well. So in Ayurvedic terms, we view it as underdeveloped brain, or in terms in Ayurvedic platforms, I would say that it's a Dhadukshayam of Mastulinga Majja, which has happened. Whenever there is a Dhadukshayam, there is a Vadavritti. As this Dhadukshayam has developed in the very initial stages of life development, brain development, the Sahaja Vyati, Acharya has told that it won't exist as a Egadoshaja Vyati. It will exist as only as a Sanipadika Vyati. Because many dhadus are not developing properly. So an erroneous or Sanipadika Rogavastha is there. But Vata is dominant in that. So I will call that Vadottara Sannipada Roga, where Dhadukshaya is dominating. Naturally, Madhyama Roga Marga is involved. Yoga Adhishtanam is usually Shiras, because the brain impairment or brain underdevelopment is the reason behind. But having the manifestation in different parts of the body. When it's a diplegia, it's Adhakaya Sadha. When it's a hemiplegia, it's a Pakshavada. It's a quadriplegia, the entire body is involved. So Vyaktisthana can differ, but Rogadhishtanam is in the Shiras. So we can incorporate the management strategies of Vadavyadi Chikitsa naturally. Then Kashyapacharya has detailed a roga termed Hakkaroga. Hakkaroga Adhikaranam Acharya has told that Bala Samvatsarapanna Padabhyam yo na gacchati. Even by the age of 1 year, baby is not able to walk properly. We call it as Hakkaroga. It's a direct indicator of a development delay. No acharyas other than Kashyapa has told a disease called Hakkaroga, or no one has addressed a development disorder like that. But sad to say that many portions of that chapter is lost. But he has beautifully said that this brain impairment can happen due to diseases like meningitis, encephalitis, graha rogas. Many systemic diseases can also get into the brain underdevelopment. Garpini Vyadi can also result like that. Elaborate description of Hakkaroga is there. So naturally, Hakkaroga Chikitsa should be incorporated there. Then certain birth injuries can also lead into these defects like cerebral palsy. So some perspective of Shiro Marma Abhika, the Chikitsa should also be incorporated. But totally it is the variations of Snehana, Svetana and Vasti which should be incorporated over there. But as it's a child, Snehasveda should be done with very utmost caution. But it's very effective in triggering the neuronal developmental axis of the child. This is a video of a baby with quadriplegic CP, like all 4 limbs are involved. The cortical fisting is there. He is trying to hold, his head holding is defective. He is trying to hold his head, but he is unable to do so. He is trying very hard. Then slowly, physiotherapy is along with Ayurveda treatment is with the help of calipers and collars, we taught him to head holding. Simultaneously, Ayurveda Panchakarma treatments was going on. Slowly, he learned to hold his head and started sitting with support. But it was not perfect. Then, independent sitting. See, independent sitting without support. Then slowly standing. He was really afraid to stand initially. With support, make him stand. Calipers, everything was used simultaneously. Slowly standing without the help of a caliper. Now, this is our dear kid. He's walking around. He has a like walker so that he is safe. He is wearing caliper so that his knees are not bent, but we can make him walk even with single hand support. So it's a long story, and this spasm, that is promising story of this quadriplegia. Quadriplegia is actually the toughest situation, and among the cerebral palsies. When compared to diplegia and hemiplegia, this is toughest one. So I was trying to show the picture of a quadriplegia so that the other ones are very, very much easy.
Ma'am,
Yeah.
when Dr. Anju has asked about this video, that is for how many months you have got this much results, ma'am. And before that, I truly appreciate your compassionate ground on the treatment and the patience, because this is not a very easy task. So how many months you took for such a change for this baby, ma'am?
Quadriplegic brain is actually a severe brain insult. It won't happen over months. It happens over years. This is a 3.5 year story which I showed in front of you with few pictures. So it's like from teaching the baby to hold the head, that is increasing the supply or neuronal supply towards the neck muscles, shoulder muscles, teaching him through the incorporating physiotherapies or internal medications, changing that external therapies, slowly doing Potali Vedas, and everything. It's a long procedure. Usually one course of treatment, I give it for roughly about 6 weeks. Then intensive treatment starts. Before that, I give internal medicines for Deepana Pachana and Srodoshodhana. Slowly after giving the internal Deepana Pachana and Srodoshodhana medicines, I start with Vata Shamana treatment. Then if the baby is fit for suit for external therapies, I take him to external therapies. I have seen that external therapies make wonders in the brain development. And when the baby is so young, the Snehas Vedas should be done with caution. Usually, Potali Vedas will be contraindicated in younger ages. Then we can go for Vata Shamana, Pradeha, Pralepas. You can go for that. Vasti works wonders in such conditions. It's an unparalleled treatment. Even after the age of 1 to 1.5 years, I do Vasti. Even Kashaya Vasti and Matra Vasti, I do regularly. So this is the story of 3.5 years. Maybe I think the baby might have taken 4 to 5 courses of treatment in this period, and we hope he will be able to walk independently. Now it is like in this stage.
Okay, ma'am, really appreciable. And I think it's a task for to convince the parents also because it takes some time to show the results. I think it's truly challenging to convince the parents also.
Actually, convincing the parents, I don't feel it's too tough because they get first they will be training the baby with physiotherapy, and they have seen the results of physiotherapy, and they know how the physiotherapy works and what's the limitation of physiotherapy. Physiotherapy seems to be effective bit, but once you stop the physiotherapy, the results you got with that will revert back. Regarding all these developmental errors, physiotherapy is having, we call it as withdrawal results. It will reverse back. Once you add Ayurvedic management or Snehasveda along with that, that withdrawal effect of physiotherapy just vanish out.
Okay.
Once you get to that, that is there forever. That's an ability of our internal Snehasvedas, especially the Thaila Snehapana is very effective in such conditions.
Okay.
And then comes once you assure it with external therapies, the muscle atrophy, the muscle spasticity, everything gets on relieved. And slowly, but it takes, I should actually appreciate the mother behind.
Okay.
It is in this snap, the lady on the left side is his mother.
Okay.
I should appreciate her patience and her like perseverance in doing such therapy and encouraging the child. But it is like every time when I meet her, she say that she's very thankful for the Ayurvedic treatment because the baby is maturing. Otherwise, baby had been on that like laying without any activity for long years. Now at least the baby is able to roam around the home like with a walker.
Okay.
So it's a long story. Maybe it takes another couple of years to make him walk independently.
Okay. Okay.
But diplegia and hemiplegia is not that tough enough.
Okay. Okay, ma'am. Thank you.
One more question, I think, in the query. Ma'am, is there is the Dadukshayam. Can we do Brahmana therapies like Nyavarakiri or Nyavaratepa? Is it advisable or not? Even though it's a Dadukshayam, it's not easy to get patched up this Shaya, especially in the deeper Dadus. So as per my experience, directly going into a Brahmana therapy won't work. Because Srodho Shodhanam, the concept of Srodho Shodhanam is very, very, very much important. You do feel that it's a Kevala Vada Vyadhi, but it's not so. Srodho Shodhanam should be that main thread of management. Don't go for a Brahmana therapies in the initial phases. Start with a Mridu, Yuksha Svedas, then you can slowly slip into Snigdha Svedas, and then end with Brahmana Svedas or Brahmana therapies like Shaktika, but only in the last end. With acquiring enough Srodoshodhana with Snehasvedas and Kashaya Vasti, only end with a Brahmana therapy. Don't ever give in Brahmana therapies like Shaktika Shali Pindasveda in the initial phases. That Srodoshodhana, actually we are blocking that, and the process of scope of improvement is actually blocked by that. And baby will start to put weight, and even he won't be able to like hold his body as such. So I won't, in my clinical experience, I won't entertain to do this Brahmana procedures in initial.
Okay, ma'am.
Okay. Another child. He was an Arab child, again with spastic CP. The physiotherapy was going on there in his native place. He is trying to stand on his knees. They are training to stand on his knees. As he can't stand alone, he is trying to stand on his knees. So he came for Ayurveda treatment. See, he is learning. This is only with one treatment. One course of 1.5 month. He started walking of his own, but with support of that caliper. This is again another case of spasticity, but it's more towards diplegia. It's not a quadriplegia. He has head holding. So diplegias are more easy. The difference in management strategy regarding the spastic and ataxic. Ataxic, maybe you remember that loss of balance and the like legs were spaced, wide spaced. And so the ataxic is actually hypotonicity, or the tone of the muscles is too, we feel that baby is too floppy. So even though it is Thadukshayam happening in all the cerebral palsies, but ataxic cerebral palsies are like that Gatra Gurutvam is more, Sandhi Shaidilyam is more, that Guru Gatrata is too much experienced by the baby. Whenever you see a floppiness, don't go for a Vada Shamana Chilisa. It is with the symptomatology. The Kabhavritti is evident over there. So ataxic CP, the management is totally different from the spastic CP. So you should adopt a Kaphavarana Vata Vyadhi Chilisa here. Then Rukshana, Rukshasvedas and Chodana should be given important. Don't go for Sniktana or Brahmana Chalapi. Here in ataxic cerebral type, these Brahmana Svedas or Brahmana treatments like Shaktika Shali Pinda Sveda is strictly contraindicated. You will worsen the condition. So whenever you see a floppy baby, you go for Rukshana or Ruksha Svedas. Don't go for Brahmana therapy. That's the main difference you should adopt. So, Rukshana, Rukshasvedas, you can also, usually Rukshasvedas like Udvartana, Kadikiri, Avikiri, everything can be done. Takradara, everything is Rukshas. And here I have tried for Ruksha Upanaha, Shiro Upanaha as well. Shiro Upanaha is very effective in managing such Kabhavarna Vada Vyadis. Much potential in doing so. Local Ubanaha and Shirobana is also effective. Another baby with floppy baby with hypotonicity. This on my consultation table. She doesn't know to walk by herself. This after treatment.
Really appreciable, ma'am.
Able to walk without support, but still the gait is not proper.
How long you took, ma'am, for such a change in this patient?
This is all this diplegia, able to sit, and one milestone is usually gained with one treatment.
Okay.
Only quadriplegic cases need repeated sittings and treatment because it's too tough. The brain repair is too tough.
Okay.
Another case with choreothetosis. Choreothetosis means the dancing movement, which is evident. As I told, it's a case of exaggerated bilirubin encephalopathy. Spasm is not there, but still head holding hand. When she tries to move one hand, the other hand and head also shows It's not under control. Choriothetoid CP. After 2 treatments, she has started walking with support. But still a bit of choreo movement is there. You can see the choreo movement still. After 1 more treatment, she is better. The choreo movements has come down. This is regarding choriothetoid CP. So I think we have touched all the 3 cerebral palsies. The spastic cerebral palsy, we can go for Brahmana, but start with Srodoshodhana. That is Brahmyastu Mrudu Lankhet. Lankana, Srodoshodhana is very needed, and slowly you can move to Brahmana. That is spastic one. But Brahmana is strictly contraindicated in ataxic or a floppy baby. Then choriothetoid also, Brahmana is contraindicated. So I am leaving the cerebral palsy. And one more video about, it's not cerebral palsy, it's actually spinal muscular atrophy. Spinal muscular atrophy is like a genetic oriented disease when the anterior horn cells of the spinal anterior horn cells get degenerated over time. It's a genetic oriented disease. So, see, baby can't actually hold the weight in the upper limbs. See, he falls down. Very intelligent enough, but can't hold the weight on the hands. See, able to hold the head, weight on the and leg, can lift his hip as well. Now the baby has improved much more and he is able to stand with supports. So this is my spinal muscular atrophy. The same management protocol as similar to like ataxic CP, like Kapavarana Vada. But as the Thadu Pagam is going on, better to avoid Ushna, like Atyushna Svedas here in the spinal muscular atrophy, but responding wonderfully. This is another case of genetic abnormality. It is like actually Cry-Du-Stat syndrome. It's a genetic abnormality causing a brain delay in development. See? Incoordinated gait. You can see that extreme microcephaly or the small head for him. So there's an intellectual delay and also speech is also delayed. For him, gait has improved a lot, but we are still lagging behind his language development and also his intellectual development. The main thing is that we have started with delay. The age from which the Ayurvedic management starts is very important. If we start the Ayurvedic management intervention as early as possible, the effect is very much. If you delay the treatment, initiation of treatment, like after 5 years, the main brain development has already happened and it's only a small window left to you to manage the brain. So the early initiation of development or early stimulation with Ayurveda treatment is actually, that's a nutshell behind the management success. So here, if we could have got the child in the early years, we could have addressed the microcephaly and also the other language development delays like language and socialization error is also there. See, his hand flapping also. Gross motor development has improved, but still that stereotypic hand flapping, intellectual delay and language delays are still persisting. So I was trying to stress upon the importance of early development. So this we were speaking about static encephalopathies, like the encephalopathy which won't worsen over time. So if you are managing it, it will improve. It won't worsen over time. But be cautious. Not all kids with walking difficulty, it's not static encephalopathy. Progressive encephalopathies are also there. So you should be very cautious about that. The progressive encephalopathies, I'll show certain videos. Progressive encephalopathy means certain diseases which has a development delay and it progresses or worsens over time. Baby won't be able to, child won't be able to walk properly and the parents will be narrating. And now the baby is having difficulty in sitting as well. Now the baby's deglutition abilities are a bit affected. Now his speech has regressed back. So it's a worsening condition. So when you come across a baby with a development delay, make sure that it's a static encephalopathy. Otherwise, progressive encephalopathies is actually risky to handle with. A small example, a case of progressive encephalopathy. We call it as, this is a case of leukodystrophy. Leuko means white matter. Dystrophy means it is getting degenerated. It's a neurodegenerative disease. It's a progressive encephalopathy. The disease is called hereditary spastic paraplegia. The condition was a genetic error. So the girl aged 10 years, a progressive difficulty in walking since baby was, actually the girl was walking well. I'll show the video first and then go to this is the video of the child. She was walking perfectly by the age of, walking perfectly by the age of 3 years. Slowly, when she turned 7 years, mother noticed that she had a lordotic gait. See the lordotic gait. And the heel was bit up. By the age of 8 years, she developed a scissoring gait. Fastly, her gait worsened and she could only walk with the support of gaiters. And when she came to us, she couldn't walk at all. She was in the bed. This is a stage when she came to us. See the lower limbs? It was very spastic and fixed. She couldn't even touch the floor with a toe. It was very painful. And it was sad that this little girl could sing very nicely. The film songs she was singing very nicely. And as the age progressed, her ability to speech and language also regressed. and she was finding very hard to even speak. So that's the history of her progressive difficulty in walking last 5 years, and visual acuity was also reducing. Her vision was getting blurred and blurred. Clarity of speech reduced. It was a non-consanguineous parentage, tall walking, and as you see in the video, it's explanatory. So they consulted several doctors, and treatment they gave Syntopa, Pacitane, Baclofen, everything they tried. But there was no result and they stopped. Higher mental functions were intact except for that speech dysarthria was the muscle tone was extremely spastic and the power was reduced. So they went for an investigation before they came to us, and the DNA report, genetic report showed that it's a genetic error in the FA2H gene, and it's a spastic, hereditary spastic paraplegia. So it was a de novo mutation, and it's actually a white matter degenerative disease. So as it's a degenerative disease, we considered it as regarding the etiology and the symptomatology. We considered it's a Vata Kapha dominant Vishama Sannipada Vyadhi, which are genetic causes, Sahaja Nidanada, and it's a worsening Dhadukshaya, which is happening day to day. And the Dhatvakni supporting that Dhatu was defective, Maja Dhatu was defective. So when the Dhatvakni Mandya is we should have in mind about the Dhadukada Amatva as well. So the Dhatus involved were Rasa, Asti, Majja, and Mamsa Dhatu, everything was involved. Snayu, Sira, Kandara were also involved. Madhyama Roga Marga was elicited. So it's a genetic disease having a progressive course. So treatment protocol was Dhadukada Ama Chikitsa was adopted over that. So Thama Shamana, Deepana Pajana treatment, and also Dhadukada Pajana Chikitsa, like Shaddaranam, everything was adopted over that. Whenever there is a Dhadukada Ama, it's better to include a Levishahara Chikitsa also in that, like can include at least a Vilvadi Gulika in your management protocol. So extreme wasting was the Shosha Chikitsa. Shosha Chikitsa is a wonderful management protocol in such cases where we can attain that Srodha Shodhana very easily. And after attaining that Srodha Shodhana, slowly going to the Vada Vyadhi Chikitsa slowly. Deepana Pachana was done here with the Kalyanaka Kashaya and Shaddarana tablet. Kalyanaka Kashaya was used here. Rukshana was done with Thanyamlatara, and Utsadana was done with Kolakulatadi Churna in Dashamula Balakshira Koda. Utsadana was turned to be very effective. It was that cornerstone in the management. Utsadana, the baby, actually, she attained the confidence to walk, to initiate her walk was attained with the Utsadana actually. Srodha Shodhana initially was done with Shatpala Krida and Swarna Basma with honey. Then later we shifted to Kalyanaga Krida because the speech was also involved. So shifted to Kalyanaga Krida and with Kalyana Avaleha Churna. Dipanchamuladi Kashaya was done. And after attaining the Srodha Shodhana, slowly slipping on to Snehana therapies, like we introduced Bela Thailam with much caution. Then it was Upashya. We slipped into Patrapodala Sweda with the Anvantara Thaila. As vision was also involved. Aschodhana was also done with Jivantyadi Tarpana Krata. And as a Rasayana, we gave Shiva Gulika and Ashwagandha Rasayana. This is after one course of treatment. Again, back to walking. But still the legs are not okay. But she could walk at least with the help of calipers. But as this is a genetic disease, it needs much time and patience, both from our medical team and also for the patient, for this arresting the progress and then improving the condition. So that is regarding progressive encephalopathies. So similar with peripheral neuropathies, I will skip it out. This is a peripheral neuropathy where that you can see that foot drop. So the flapping foot you can see. You can't walk in a straight line. That foot drop you can see. This is the after treatment. Now see, he can walk in a line better, much more better, but still he is suffering to do so. He's slipping out. We are training him to walk in a straight line. Actually, I would say that he was a very cooperative child. In spite of his illness, his attitude was very nice. He was trying very persistently, and this is after treatment. See how he could walk. This was peripheral neuropathy, genetic oriented peripheral neuropathy, where the typical glove stocking sign was there. The similar glove stocking sign you may be familiar with. That sensory innervation towards the lower limbs were delayed, and that peripheral neuropathy signs were more and similar in the hands. Again, Kapavarna Chilisa was adopted here. Then coming to Hydrocephalus. Hydrocephalus, it's like classical sun-setting sign. Because of the pressure of the intracranial pressure, you can see that that eyelids going, the cornea going down. The classical. Hope you can appreciate this sun-setting sign. Sun-setting means as if like the sun is setting, that entire eyeball is going down, and you can see the sclera above that eyeball. That's a primary indicator of increased intracranial pressure over that. And without head holding, this is the after treatment picture. This again, it's a very tedious case. Took years to be like this. It's like after, I think, 3 or 4 years, it's like this. But hydrocephalus also responds wonderfully with our management. There's another case of hydrocephalus. It came to me during the COVID period. So our hospital facilities was not enabling us to admit an acute hydrocephalus. So I advised an external lepana of the head, the Krishnadi Guliga, which we usually prescribe in Kerala. It's applied in Tenginde Tondinde Neera, applied on the scalp. They gave the picture daily. You can see that bulging fontanelle. It was applied on the scalp. And again, you can see that sun setting sign in him as well. But this young baby, he was not able to even open the eye fully. You can see that classical sun setting sign in both eyes. And this is the perfect baby. Sun setting has vanished, and the language skill are also perfect. This the video at is 8 months, but still you can see that head size is big. You can see that frontal bossing, you can appreciate. But now I think he might be 7 years. They are still in contact with me. All his milestones were proper. We had 2 more treatment courses for him because parents were very anxious regarding his skills. Once he developed a seizure episode at the age of 2.5 years. But till now, that seizure episode didn't demand any anti-epileptics, and I think he's around 7 years now. It's perfectly okay. This acute hydrocephalus, I don't say that all that acute hydrocephalus will respond, but classical Virechana classical Virechana and this external application is very effective in managing the hydrocephalus conditions. I will say that all the hydrocephalus will respond. By Shri Ratnavali, there is Pita Mulyadi Kashaya Yoga, which is Pita Muli is actually a variant of Kadu Rohini, that is Pita Rohini it is. Pita Rohini is having very much purgative effects. So even though Virechana is contraindicated in pediatric age group, it's the only condition where Nitya Virechana is indicated. When that extreme fatal conditions are in front of us, we are actually bound to violate the rules, and Acharya itself says that Nitya Virechana is indicated. So Pita Rohini, Pita Mulyadi Kashaya is very effective for Koshta Shodhana in these kids. So when we give this Pita Mulyadi daily, make sure that we adopt that Nitya Shodhana protocol. So you give the Kashaya in once a day and do give Sakrita Yusha the other time. If you are giving the Kashaya on the evening, morning you should feed the baby with Sakrita Yusha and all other food items. Ensure that fluid maintenance. Then Virechana on the night. Especially for hydrocephalus, night Virechana is more effective because fluid pooling happens more in the night. And also external Lebana, which is having Shobhara properties, are also very nice. So I think I am taking more time than expected for dealing with this gross motor development disorders.
It's okay, ma'am. Like how many slides? It's okay, ma'am. If you can finish within 5 minutes, it's okay. Actually, all are interested to hear because you have vast experience and all the videos that shows your dedication for the patients and truly appreciable. And so actually, I think nobody wants to stop this session. Anyway, because of the time constraint, we can restrict to.
Yeah, I will wind in another 5 to 7 minutes.
Sure.
So coming to behavioral disorders. Behavioral disorders are again a vast area. So main three behavioral disorders which are on the rise are, main one is autism spectrum disorder. We'll deal it with a bit more detail. And second one is hyperactivity and attention deficit. We call it as attention deficit hyperactivity disorder. And the third one is oppositional defiant disorder. Oppositional defiant, I will say two more words like the baby finds happy, I won't say the baby, the child finds happy when he opposes someone, when he denies someone, when he irritates someone, he finds happy. He finds happy when he is doing some negative deeds. When the parents ask him to don't do such, he will purposely make sure that it's done in the wrong way. So irritating someone, denying the commands, everything, he feels happy. That we call it as oppositional defiant disorder. Again, it's on the rise nowadays. Maybe the nuclear family, maybe the high peer pressure or the school pressure for the family, maybe the defective child rearing habits, everything is contributing to that. And also our defective food habits regarding the child, the more of junk food, everything is contributing to that. So three main are oppositional defiant disorder. It's one. The second one is attention deficit and hyperactivity. The baby is so hyperactive, like he will roam around like as if driven by a motor. Even after all this hyperactiveness, he is not tired by evening. He is still full of stamina and vigor and valor. And parents are actually fed up with controlling these kids. So it's like he's so hyperactive that he can't pay attention to a single thing. Even before he's playing his toys, he can't pay attention. He'll play with one toy, then leave it after a few seconds, go for another toy, play it for another few seconds, like drop it there. He won't care for toys. He's distracting the toys, everything is there. Actually, their pain sensation is also limited, so they feel like hurting others also. And the first place goes to autism spectrum disorder. It's like alarmingly increasing it is. It's actually a behavioral abnormality where the child doesn't know how to behave actually. Slides, are you visible? Is it visible for you, ma'am?
Yes, it's visible. I think one doctor has message. I'll take care of that, ma'am. You can continue. It's visible.
Okay.
Okay.
Its prevalence is fastly increasing. Prevalence chart, it was very rare disease when I was studying in my BAMS degree. We usually go running in the OPT to see one autistic case. It was 1 in 5,000 or something. Now I get more than 10 to 12 new autistic cases every in OPD. So it is like 1 in 83 kids. See the alarming rate in increase. Those genetic factors are the brain structural and functional derangement of the brain is the, and most important is the metabolic derangement is there in these kids. Their acne is so weak that it's unable to digest many of the heavy proteins and certain carbohydrates as well. So what happens? There is a in genetically oriented acne mandya which is happening in these children. CNS pathologies are naturally there because the brain functionally and structurally brain is underdeveloped. So what happens? Because of this acne mandya, or we call it as digestive errors which is happening in these kids, their gut is actually the undigested food matters is getting leaked out through the gut to the systemic circulation. So this undigested food matter in the systemic circulation, actually we call it as Agni-mandya. Then, so the ahara is in the amavastha, in the gut. This ama is getting leaked out in the systemic circulation, causing Tadukata amavastha. And then into the circulation. So getting deposited in the brain, in this affecting the brain functions, everything. So the baby will be having 3 features. They doesn't know how to interact with the society. The social interaction will be impaired. They will be having very restrictive, repetitive behaviors. And their speech and language will be totally involved. The receptive language they doesn't know. They, even though their hearing capabilities are very nice, they don't understand our language and they don't know how to speak. So both receptive and expressive languages are there. Pointing also, the baby doesn't know how to point. And if we point something, he doesn't know how to look at that. If we point, see that crow over there, he doesn't know where to look at. He may look at the finger or something else. So that function of the brain is also lost. So these kids won't be having eye contact. They don't have peer relations. They don't want to be cuddled actually. They ignore the other parents. They prefer to be alone actually. Their own, playing with their own body parts. They don't have proper sleep rhythm. Some days they will be sleeping in the day. Sometimes they will be sleeping in the night. Temper tantrums, self-injurious behavior, everything will be there. So actually, this happens, the root cause is Agni-mandya over there. Certain proteins like milk protein, they won't be able to digest. So the acne is genetically weak. The gut microbiome is entirely distorted. So the digestive assimilative skills are distorted. So the base correction should be there in the acne. The base correction should be there in the gut microbiome. And then only go for having a correction in the brain. Many a times I have seen that whenever you see a child with autism, you tend to give some medicines having Brahmi or something like that, a neuroprotective or a neurostimulant drugs. And this hyperactivity, irritability, everything goes on high. They go into a still more worsened condition. So the treatment protocol here is like correct the acne first, and it may take 1 or 2 months to have a correction in the acne. Once you have a correction in the acne, do manage the Dhadukada Amatwa give a Vishahara drug as well. Then when the Agni Mandya is long lasting, Kabacha Krimi should be, Kabacha Krimi management should also be incorporated there. Then only after having a Agni Mandya correction, then Dhatu Agni Mandya correction and systemic detoxification, we can go for correcting the structural and functional derangement of the dhatus or brain. These are the videos. See, this is the normal behavior. Actually, he is happy finding one of his dress in the cupboard. But the way he is expressing the happiness is actually distorted. This is another baby with the spectra. You can see the stereotype turning around, that purposeless making sounds, biting his hands. This howling doesn't indicate he is irritated. It's his, actually, it's a normal pattern. He howls a lot, he screams. We can't pacify him actually. See the stereotype hand movements. Certain kids are very aloof as well. So I will skip around. Concerns in the Ayurvedic platform is regarding the Agni and Agni alone. So do correct the Agni first and then correct the Rasadhatu Dushti and then only go for managing that brain, the underdeveloped Masthishka Majja. Don't touch the Majja until and unless the Agni is corrected. Even if with this Agni Deepana and Amapajana, you will get good results. If you can do a systemic detoxification, the results are much more better. This is a child with this is a parents, severe hyperactivity. He's trying to poke his fingers in that electric socket. He's not fearful of the height. He makes all sorts of dangers. He climbs the window and then comes down. This after one course of treatment. See? He's regarding his parent and actually a smile has occurred in his face. After the second course, this is a hospital ward. The boy who is walking around is our hero. He is having social interaction with other kids. That screaming, everything is lost. He is imitating other kids. And this was our hero in the initial stages with an expressionless face and like no eye contact and all. And after first course of treatment, this is our hero with eye contact. And after long years, this baby was in my initial phase of my career. Now, last month he came to visit me. He is 19 years old, and this is our hero now. He is leading his normal life, and so it's nothing like autism is incurable. It can be cured. It can be bettered, made better with our effective management, like managing the Agni and then. So I know I couldn't give much explanation regarding the behavioral disorders, but I would feel happy to answer your queries if at all. It's a vast topic, so and we're extremely thankful for the opportunity, and would feel actually it's a recognition or a extremely happy moment for me to be with the KL family. Once more. Thank you. Thank you.
Thank you, ma'am. Thank you so much for a very insightful and that engaged presentation. And thank you so much for sharing your rich clinical experience. It's truly inspirational. And in the last video, we can see that actually the smile in the child and the parents, actually it's truly it's beyond the words what you are doing and your dedication to this field, ma'am. Thank you so much for sharing your insights. And now we can go for the Q&A session. And after the Q&A session, we have a short product introduction from Kerala Ayurveda Limited, which will be presented by Dr. Rahul. So now we can directly go for the Q&A session. And I can see the chat box also, it's overwhelming with questions. I think all the participants are eagerly waiting to get your answer, ma'am. So I will, we have got many questions. I will ask some, as there is some time constraint, I will ask some of the questions. Ma'am, I think two doctors have asked regarding chorioathetoid CP, and one doctor has asked what is the difference between chorioathetoid CP and a spastic CP.
Actually, that systemic examination of CNS will reveal that spastic CP is a condition where spasm is a very classical, that is hypertonia will be there and also hyperreflexia will be there. All the deep tendon reflexes will be exaggerated and you can even get a clonus in ankle. So the classical exaggerated deep tendon reflexes with hypertonicity is the classic landmark of spastic CP, where in chorioathetoid CP, you won't get a spasm. All the limb movements will be possible. The range of movements will be fully accurate, but when the baby is not doing anything, even you can see a bit, we can feel like bit hypotonia over there. But when the baby is doing something, a bit hypertonia is there, but it's not spasm. Deep tendon reflexes won't be exaggerated. That classical involuntary chorioathetoid movements will be there. The dancing pattern movements will be there. If the baby is trying to move one hand, the other hand will also be work. And the mouth will also work. So that is like involuntary movements. That's a specific word. Involuntary movements will be the classically present in chorioathetoid CP. It won't be spastic, and the DTR or deep tendon reflexes won't be exaggerated. The dancing movements or the involuntary movement is a classical representation. Hope I'm clear with.
Yes, ma'am. I think it's clear to whom who have asked. And the next question is, please explain, ma'am, regarding the correlation of ataxic CP and Kabha Avaranavata.
Yeah, ataxic CP, like even though Tadukshaya is there, that dosha assessment should be done with the symptomatic signs which we see.
I think your network
So
is
when we analyze the symptoms.
Yes, ma'am. Now it's clear.
Okay. So the dosha assessment should be done from the symptoms as well. So when the baby is having this floppiness, extreme gatra guruta is the santi shaidilya is the hyperextensibility of the joints will be the. So Kabha lakshanas will be dominating when we assess the symptomatology. Vata vritti lakshanas we can't elicit in the baby. Even though we know that it's a Dadukshaya, while analyzing the symptoms, we won't get a single Vadavritti Lakshana. What is the condition when Kapha Lakshanas are dominating and we don't find any Vadavritti, but we know that there is a Dadukshaya? So exactly that's the condition of Avarana when the Kapha is covering or getting Avarana of the Vada. So even though there is a Vada Vritti, this Avaraka Kapha is covering over that. So the symptomatology will be mimicking the Kapha Vritti. And it will be masking that Vada Vritti Lakshana. So don't go for Thadukshaya Vada Vritti treatment. Adopt Kapha Avarana Vada Chilsa. Kapha Avarana Vada Chilsa is every time Yukshana, Yukshasveda and Srodoshodhana. It's never Brahmana. So it is many treatments are contradictory over the Vada Vyadhi, normal Vada Vyadhi, Snehanam, Swedanam, Brahmanam is contraindicated here. It is Ruksham, Rukshasvedanam and Srodoshodhanam. So don't start with the Snehana internally or externally. Internally and externally, it should be done with Rukshana, and then slowly the next phase is Rukshasveda and then Srodoshodhana. Don't go for any Brahmana Snehanas or any Brahmana treatment over.
Okay, ma'am. We'll go for another question. When doctor asked about Hydrocephalus.
Pardon? I couldn't hear you.
Is it audible, ma'am?
Yeah, now it's perfect.
Yeah, Shirolepa, which of the Shirolepas we can view in hydrocephalus cases?
Hydrocephalus, it is Srodoshodhana Shirolebas, Salila Shoshana Churna and all elaborated in the text. But usually easily available is like Krishnadi or Kartavata Guliga. It's locally available in the market, which is my favorite. It is like dried aloe vera juice it is, and a bit more drugs in that. It's very effective in managing Shobha. Even in elder kids, you can do it with Shigru Swarasa, but younger kids, due to this skin irritation, Shigru Swarasa is usually avoided. And the juice of the tender coconut husk is usually taken as the medium for external application. You can even think of Nagaradi Lepachurna over there.
Okay. Okay, ma'am. One more question, like after stopping the treatment, does progressive encephalopathy revert back?
Yeah, in progressive encephalopathy, actually, it's a fatal disease. Fatality is very near. So you are not supposed to stop the treatment and withdraw the medicines. The Panchakarma procedures or the external therapies can give a break, but the patient should be on regular follow-up every month with Srodoshodhana, Chikilsas and internal medicines. And maybe you have to repeat that external therapy in a period of, maybe depending upon the severity of the disease, you have to repeat it once in every 5 months or something like that. But parents will be usually sticking on to the treatment because they know that the worsening of the condition, clinical worsening is very evident. So usually they stick on to our medicines.
Thank you, ma'am. And one more question, disability in early stages, how we can do the Prakriti assessment in the patient is challenging because some motor system will be affected like that. So how we can assess the Prakriti in such patients?
Very wise question, actually. When the baby is having a disability in very younger ages, the Prakriti assessment is really tough because the Vikriti is dominating. So maybe from the skin or the koshta, it will reflect the Prakriti, but it's very tough to assess. So we do assess, give weightage to the Vikriti assessment and then do the management. Prakriti won't be actually clear.
So thank you, ma'am, for the answers. I think we have covered a few of the important questions. And there is some time constraint. That's why we couldn't attend all the questions. And actually, we have planned for a product introduction by Dr. Rahul, but due to some network issues, he couldn't deliver the presentations. Sorry for the inconvenience. So it's a time to tell our gratitude from Kerala Ayurveda towards you, ma'am. And thank you so much for such an insightful presentation and such an energetic and on the presentation is with a clarity and you have explained every detail and the rich experience that we can see in your videos, what you have shared. And thank you so much for the inspirational presentation. Thank you so much, ma'am, for sharing your knowledge. And thank you so much for your time. And thank you for all the participants who have actively participated with so many questions and who made this presentation, this program a true success. Thank you so much. And thank you for Dr. Rahul and all the technical team, the IT department, and everyone who has supported us for the completion of this session. Thank you so much. Thank you, ma'am. Thank you, everyone. Have a good night. Thank you.